like that, you can educate them so that in the long run it will be helpful for us. Okay. Mm. Have you informed to the DMHO about the bad cases so that they too should have been awakened and informed of the concerned people what they are doing? That is that we have to do. DMHO, we have to tell some from some places we are getting bad cases. That means she will give some training also. She may ask her to, they may go to general hospital or this hospital for little training or brushing up their knowledge and something like that, about blood, non-availability of blood. That is also important thing. So if that doctor is very shrewd enough, we can ask them to bring blood from some places and tell. So IUD cases, there are two cases. IUD, they can be managed some there itself, they need not refer this case. Sometimes, some of the referrals, they are afraid, not afraid, they want to get rid of that cases. They are looking like that. Okay, not that way they cannot do something like that. The places where we are quoting, all the places they are doing cesarean section, hysterectomy, everything. I don't know what reason they are. Some cases they should have tackled there. Some reasons will be social reasons or something like that. Okay.
Actually, many cases they can manage there itself. But thing is, there are many cases. Many times, what happens is they refer the cases to us, thinking that because of the legal issues, legal problems, something will happen to the case. Anything, they will. The people will not keep quiet. That is the reason. And all the cases, whatever they're getting referred to us, like a bad cases, we are informing to the DMHO. We are telling, we are soon after the admission, we are telling this is the type of case we received, and all we are informing also that things are. So regarding because of the financial issues and because of the associated complications and all, they are not coming. But many times what we receive the thing is proper documentation is not there. Even without starting any treatment of even fits cases are there, conversions cases are there, even starting of any of even max, all our gynecologists they know about the how to manage a case of eclampsia. But in spite of that, they are not giving even Maxel for that. Some are giving, some are not giving. They are just directly referring the cases to us. Anemic cases, more than 4 grams, hemoglobin 5 grams, 6 grams, and all they are not doing. And all types of hemoglobinopathies, cardiac diseases, CNS diseases if they have got, and hemoglobinopathy, sickle cell, thalassemia cases, and all. They are coming to us, but they are getting delivered. Most of the times, what happened is all the 98 cases are successfully treated. They were discharged. They were doing well also. So only 2 deaths were there. 2 deaths are already in a bad condition. They came to us and they died. It is so everything is we are informing the India Medical and others higher officials. But we never referred any case to other hospitals. No, even KGH also were hardly maybe I think less than one. I think one case maybe things. We are not referring any cases because all the facilities are available here. So we are taking up all the cases. We are not referring any case to them. Referring means something wrong. Maybe financially they are not sound. They cannot afford. And in that cases only we are referring to KGH. But it is only one case maybe. Very very one maybe 1 or 2 cases. So we are referring the case that those cases which are going to die shortly. So that type of cases we are sending.
I must congratulate you, Department of Obstetrics, for doing good work, publishing that paper. And you made good recommendations also. You made a good recommendations.
Yeah. You
that-
made good recommendations because every PHC level, all the under level, they have to be trained properly.
Did you
for-
send that recommendation to DMHO? You made a recommendation, okay, on the paper it's good. Did you send it to the DMHO for necessary action?
So we are informing all the cases, which are the cases, the bad cases that are coming from the PHCs.
You
No,
matter-
listen.
you are-
Actually, no, DMHO, she herself, she decide what to do, how to make the recommendations there. the PHCs they are coming, so and so PHCs, such a bad cases are coming, you please take care of that, like that we are telling her. She's taking action for that.
you have to write it.
Oral.
Put it on a paper, send it to DMHO, send it to the district collector, who will take care of all this.
Yes, I think you focus it to abortion cases, you know, if I am correct. Have you made MTP this medical legal? That cases, those two cases should be made medical legal. Then only they will learn. So all medical MTP, badly muddled MTPs, you have to make an the medical legal. That is mandatory.
If we make medical legal, they don't refer the cases to us.
Okay, what is there? No, that is no. Not that way. They are coming here.
No, it's not like that, because they are not qualified also. I know
Ah,
that. The people who are doing MTPs are not qualified. They're coming here, okay, we are treating, we are
Not that
giving
way.
them cure and we are sending. Huh?
MTP death should be informed. It is a medical legal case. Hmm.
Okay. Good presentation you made.
You have mentioned about the 3 delays. Are they present for all the cases? All the 3 delays are there for all the cases?
No, sir. Most of the cases had first 2 delays, sir. Especially first delay, that is delay in decision making, especially by patient and family members, sir. Like
Okay,
counseling
okay.
and decision.
Good.
And then second delay.
True. But right now, even for transportation also, the government of India has made robust measures. Even if there is an accident on one side and a maternity case on the other side, the preference will be given by the 108 for the maternity case. So I don't think there are difficulties in transportation nowadays. So it is most unfortunate. The other thing is, so second delay in transportation, that should not be there in any case as per the what to say, NHM safe motherhood initiatives, government guidelines. Even this point is also reviewed in the MDSR monthly. Is there any delay regarding that? Next, regarding the third delay, do you have any suggestions to improve anything, if at all? I don't know. If there is any delay in the third part, what are your recommendations? Or there are no delays at all? And lastly, what is in your opinion the ideal referral policy?
We majorly try to avoid the third delay, sir, because third delay usually occurs at the site to which the patient is referred, that is our center. And since we have 24-hour emergency facilities also and availability of doctors, we try to avoid third delay, sir. And the ideal referral should be the patient has to be at least stabilized before being referred, and proper communication regarding patient's condition to the attenders, and also documentation of the diagnosis of patient and any treatment that is being given to the patient has to be documented, sir. And if possible, also communicating to the center to which the patient is being referred, that is to the medical officer or healthcare provider at the emergency center to which the patient is being referred. If it is possible, communicating to that person is also important, sir.
Yeah, that's wonderful. In fact, the government has made arrangements in this regard also. Cases to be referred out has to be followed by a referral slip, and prior intimation to the place they are sending communication. But it's again most unfortunate in the sense all these high risk, particularly obstetric, all these obstetric cases should be followed by the concerned ASHA, by the concerned ANM, by the concerned health visitor, as well as the medical officer. And despite such a beautiful arrangement by the government, if we are finding difficulty in getting the patient record, is there any thing from our side to improve, to gain access to the prior documentation or Because every patient nowadays, every antenatal women nowadays is registered in the NHM portal itself, in the so-called mother-child tracking system. There is a tracking system right from becoming pregnant to till 5 years of after delivery, right? So such a system is there, and the antenatal cards and follow-up. Government has made elaborate arrangements to follow up all these cases, and it's the real time also. They cannot mug it up. That's what we are finding in the MDSR reviews. So, can we make any attempt to gain access to the prior records of the patient? Or did we make any such efforts at all?
Only 31 of the referred cases had referral letters with them, sir.
Yeah, they did not bring a referral letter. That's okay. It doesn't mean that they did not receive any antenatal care. So, have we tried on our part to gain access to the earlier? MCH got the. Yes. Yes, sir knows much better. He worked as Demon, so he must be pretty well knowing.
So, good afternoon to all. So, I would just like to add a few this thing. Basically, once an EC is recorded and an individual becomes pregnant, the first and foremost thing is identification of and confirmation of pregnancy, then MCH registration, wherein all the basic details, the antenatal, the pregnant history and all this is recorded in this thing, and the case has to be recorded as a normal case or a high risk case. What are the high risk conditions? All of us are aware. Now, once the patient is registered, the 9 months antenatal period, the periodicity of checkup based on the condition of the patient, where the patient should undergo these checkups, including a specialized checkup, all these things should be fixed as per the convenience of the patient. And this is to be followed up by the concerned ASHA and the ANM under the cognizance of the concerned PHC medical officer. If these things are done in pen and paper with the true spirit, I am sure we can prevent a number of maternal as well as infant deaths. Majority of the cases, the patient does not have a real antenatal checkup. And second thing is, we have come across instances wherein the case is identified as a high risk case, but due to various causes, the patient is not willing to come to a higher center for a proper checkup. But we do not have a mechanism wherein we take into cognizance the seriousness of the condition and convince the patient to come for the checkup, as a result of which there is a delay, and following which the patient lands in complications. Once the patient lands in complications, the time limit is so less, we have very few chances of trying to of saving the patient. As a result, because when I was at the helm of affairs, we used to do a monthly analysis of the causes of maternal mortality and the infant mortalities. And during in the process of analysis, we have come across conditions wherein 50% of these deaths, at least 50% of these deaths are preventable. These can only be prevented if the cause is identified at the early stage and necessary precautions are taken by convincing the patient. Our job is not only the identification of the cause, but also convincing the patient and ensuring that the patient comes for the proper checkup and the follow-up. If these are done in true spirit, I am very sure that 50% of the maternal mortality and the infant mortality in our areas can be prevented. So, as sir has rightly pointed out, MCH card is a very, very important mechanism. And the second thing is the details should be properly filled up in this card. Like the previous antecedent history and all these things should be properly recorded. And one more thing which I would like to stress is there are certain patients where we can anticipate some complications. So that also, that actually we can do it only when we do a proper checkup. If these precautions are taken, definitely we can help prevent a number of these deaths. That is what I just wanted to add.
Good afternoon, everyone. I'm Dr. Neelima, postgraduate from Department of Psychiatry. I'll be presenting a case of binge eating disorder. My moderator is Dr. K.M. Salahimam, professor. Identification data, a 23-year-old female patient hailing from Srikakulam, unmarried, software engineer by occupation, belonging to middle socioeconomic status, came with her father to our OPD. Chief complaints, excessive eating, inability to control eating during these episodes, and feeling of guilt after eating junk food for the past 6 months. History of present illness, patient was apparently normal 6 months back, after which she started consuming large quantities of food, even when she is not hungry within a short period. She ate until she felt uncomfortably full and reported a sense of loss of control over eating, stating that she is unable to stop or regulate the quantity of food intake. The food consumed is predominantly high calorie food such as fast food, sweets, and processed snacks. These episodes occurred 3 to 4 times in a week. These are followed by feeling of guilt, shame, and distress. Patient reported that she ate alone due to embarrassment regarding the quantity of food consumed. She leads a sedentary lifestyle and doesn't engage in regular physical activity. These symptoms are insidious in onset, continuous, and gradually worsening in frequency and severity of episodes. No history of any laxative or diuretic use, vomiting, fasting or strenuous exercise. No history of restrictive eating patterns or significant weight loss. No history of distorted body image or intense fear of gaining weight. No history of depressive symptoms, anxiety disorder, panic attacks, or obsessive compulsive symptoms or psychotic symptoms. No history of mania or hypomania. No history of similar complaints in the past. No history of diabetes, hypertension, TB, asthma, epilepsy, or thyroid abnormalities. No history of any psychoactive substance use. Personal history, birth and developmental history is uneventful. She studied up to BTech with well-adjusted behavior. Software engineer working in Hyderabad. She's unmarried. Menstrual history, her cycles are regular. She takes mixed diet, regular bowel and bladder habits. Sleep 7 to 8 hours per day, and appetite is normal. Family history, she's a second order child born out of non-consanguineous marriage. No history of psychiatric illness in the family. Premorbid personality, social and interpersonal relationships are well maintained. General mood is cheerful. Attitude to work and responsibility, she is responsible and well adjusted. Standards in moral, religious, and health matters, believer and normal religious activities. Sleep pattern 6 to 7 hours per day. Food habits, mixed diet. General physical examination, moderately built and nourished. No pylorictus, clubbing, cyanosis. General lymphadenopathy or bilateral pedal edema. Her vitals are stable. Next. Systemic examination, CVS S1 S2 heard, no murmurs. Respiratory system, bilateral normal vesicular birth sounds are heard, no added sounds. GIT, per abdomen soft, no organomegaly. Bowel sounds are heard. CNS, no focal neurological deficits. Next. Mental status examination, general appearance and behavior. Patient is well groomed, eye contact initiated and maintained. Cooperative for interview. Rabo established, normal psychomotor activity, gait and posture are normal. Speech relevant, coherent, normal reaction time and productivity, thought, preoccupation with food and eating episodes, guilt and shame regarding her eating. Perception, no perceptual abnormalities, mood, subjectively, feeling guilty about eating habits, affect reactive, range normal, reactive, reactivity present, non-labile and appropriate. Her attention and concentration, it be drawn and sustained. Immediate recent and remote memory are intact. She's oriented to time, place, and person. Average intelligent, judgment is intact, and insight is grade 4. Next. Summary, the patient is a 23-year-old Telugu-speaking female software engineer from a middle socioeconomic background who presented with a 6-month history of recurrent excessive eating episodes and loss of control. This condition is likely precipitated by professional stress and perpetuated by distressing cycle of post-binge guilt that reinforces further disordered eating, though her strong family support remains significant protective factors for treatment. My provisional diagnosis according to ICD-11 is 6B82 binge eating disorder. Differential diagnosis, bulimia nervosa and atypical depression. Points in favor, eating an amount of food definitely larger than most people would eat in a similar period under similar circumstances. A sense of lack of control over eating during the episode, eating until feeling uncomfortably full, eating large amounts when not feeling physically hungry, eating alone because of embarrassment over quantity, feeling very guilty after overeating, and no compensatory behavior. Investigations, CBC, RBS, thyroid profile, LFT, RFT, and lipid profile are within normal limits. Next. Treatment, psychotherapy, mainly cognitive behavioral therapy is mainstay of treatment, added with sertraline, SSRI. Next. Discussion. Next. Binge eating disorder is characterized by frequent recurrent episodes of binge eating once a week or more over a period of 3 months. It is a distinct period of time during which individual experiences are subject to loss of control over eating, eating notably more or different than usual, and feels unable to stop eating or limit the type of amount of food eaten. Experience is very distressing and often accompanied by guilt or disgust. Unlike bulimia nervosa, it is not followed by inappropriate compensatory mechanisms like purging or strenuous exercise. Next. Prevalence 0.2% to 4.7%. Female is to male ratio is 2:1. Age of onset typically late adolescence to early adulthood. Mean age is 23 to 25 years. This accounts for 30 to 50% of individuals seeking treatment for eating disorders. Comorbidity rates. Obesity is the most common comorbidity, which accounts for 65%, followed by major depression, anxiety disorders, personality disorders, type 2 diabetes, and substance use. Next. Systemic complications include metabolic like type 2 diabetes, metabolic syndrome, dyslipidemia, etc. Gastrointestinal, GERD, fatty liver disease, respiratory sleep apnea, obesity, cardiovascular hypertension, CAD, musculoskeletal osteoarthritis, etc. Reproductive PCOS, infertility, and pregnancy complications. Next. Treatment goals include reduce or cease binge eating episodes, normalize eating patterns, treat associated psychological disturbances, improve physical health and metabolic parameters, enhance quality of life and psychosocial functioning, and prevent relapse. Next. Psychological interventions are first line of treatment, cognitive behavioral therapy. Next. Pharmacological treatments include antidepressants like sertraline, fluoxetine, and escitalopram. Next. These are my references. Thank you.
Since 3 months, before 3 months, he was all right, you know. What happened in these 3 months? Have I made an inquiry? He is living in Hyderabad, you know.
Yes.
Is there any something has happened?
What she said was work-related stress, sir.
Whatever, so many will have stress. Everybody, there is stress going on eating, you know? Only stress.
Yes.
Is there anybody threatened him?
No, sir.
No. Have you inquired about his friends? No, 3 months.
As per what her father
No,
said,
don't father, you know. Father is here. He was there at Hyderabad, you know. Something might have happened there. That thing, that is the detective you have to do. You have to ask his friends, colleagues, what is it? Has he fallen in love with the lady? Has he deserted him? Refused him?
She is woman. She's female.
A male. So probably he's a male. Huh? Okay. Huh? These things you have to ask, you know. Simply, is eating and eating means only he is not beginning eating, you know. Only since 3 months only started this problem. Some excitatory problem or frustrating problem might be there. That we have to find out. Okay. Even
Her weight is normal, ma'am, like 58 kgs. 58 kgs.
Madam, I think Abhinay madam or Lahari madam might be the mentor. Cognitive behavioral therapy means how will it be done, madam? What kind of behavioral therapy you will give? Can you throw light on it so that we all will?
Sir, the major treatment for these eating disorders is mainly non-pharmacological, and here it is CBT, cognitive behavioral therapy. It is always done in session-wise at 3 different phases. It requires nearly 18 to 20 sessions, each session lasting for minimum of 40 to 50 minutes. So initially, yeah, as sir pointed out, the major stress has to be tightened. But every time here, father is very authoritative. So whatever history we get, it is from the father only. Even if we ask the patient individually also, she is tuned in such a way that she should tell only these answers. So parenting style here, it's very, very essential. So it might be supportive, at times it might be hindering also. So in the first stage, what we do here, there is an uncontrollable thing to eat. She knows she is doing so, but still that unable to stoppage. That is for her first cognitive distortion. So the cognitive distortions or the cognitive defects are first addressed, which should be done by her own self-regulation, self-paced. She might identify it in this session or in the next session. It is completely patient-oriented. We cannot force we can be for other type of therapies. Here it cannot, because it is her own cognition which should identify which is wrong, which is right. Then later she's going into guilt. So here what is happening, she is able to understand that she is committing mistake for herself. Then for that she should not, here there is no comorbid depression per se, as it's an acute case. So if it is there, that also should be dealt later. Then what are the reasons, she should analyze that. A specific diary will be kept for the individual patient. It's like self journaling like.
In simple way, sir, cognitive behavioral therapy includes identification of negative thoughts or the cognitive distortions, and then replacing that negative thoughts with the positive thoughts, and that we emphasize with the behavior. That is in a simpler way.
No, madam. Here, father is insisting her for a particular behavior. She might be doing this for secondary gain or primary gain or some that hysterical behavior might be how you are ruling out that hysterical behavior.
That personal reasons are totally different, not related to this thing, sir. They are totally different. That we could clearly emphasize. Mainly the positive reinforcement of the cognitive distortions, the negative thoughts are superimposed by positive thoughts, which should be reinforced and maintained. That takes lot of sessions. So currently she is able to identify and she's trying to re-modulate them. Still it takes.
How much time the cognitive behavioral therapy you will give, madam, before starting the pharmacological management? Before starting pharmacological management, how many trials of cognitive behavioral therapy you will give?
Only first start non-pharmacological, then pharmacological. You can start both. But pharmacological, it is at this stage only. Non-pharmacological is more essential here, which is a long-term for maintenance and relapse prevention. Yes.
So thank you.
I have a small doubt, madam. When I don't have any work and I'm at home, I am also in the habit of eating whatever is available. So am I also suffering from binge disorder or something of that
Not
sort?
at all, sir. Because
So for how many, after how many episodes will you label it as a binge eating
according
disorder?
to ICD-11, it is 1 to 2 episodes per week, persistently for 3 months, sir.
Right, thank you.
See, all the postgraduates have chosen very good topics. Arrange in first. Have chosen very good topics. The presentations are good, I should say, but then you never stop reading from your slides, and you are not confident. Your slides are not good, especially the second me referral case OBG Ammai. Some of the slides are very bad, but the presentation is good. The topic is good. Everything is good. So you have to, with the very idea of conducting this is you will learn so that you will present better in other platforms. But you continue to do the same. కొంచెం బాగా కూర్చో బాబు అలా పడుకుంటే నాకు నిద్ర వచ్చేస్తాను. Sit properly. That is not the way you should sit, na? This is an academic session. So, and nobody asks any questions. The people who ask questions are only Ramarao Garu, Ambedkar sir, only these people over here. Nobody will ask. No PG will get it out. Em rather doubts asla. Vinte kada vachedana. Why are you not active? We want you to be active. Ask something. It can be a stupid question, but still, you can afford to ask a stupid question. After this, you cannot. So please ask something. Clarify. Don't you get doubts? Not that all of you are experts in different subjects, right? So 3 different presentations were there and not even a single question from any of the postgraduates. I don't know what's wrong with you all. Meer anta experts are topper, lakpothe asalu hopeless. What is this? Why are you not active? Next class onwards, next session onwards, when you don't ask questions, whoever doesn't open the mouth or whoever is with the mobile will get the punishment. I will stand and watch everyone. దీనికి కూడా అసలు ఒక్క ఎక్స్ప్రెషన్ లేదు ఒక్కడ ఫేస్లో. ఎంత దారుణంగా ఉన్నారు అసలు. See, please be active. We want you to interact. We want you to ask questions or at least follow what's happening. మొబైల్తో పడుకుని మధ్య మధ్యలో లేపాలి. Dr. Bose, you have to take that responsibility of waking them up in between. That's also your job, right? No, this should not become a formality. I want this to be interactive. I don't know what you're going to do from the next week. You yourself design a punishment for them. Okay. So, okay, now coming on to the lighter side. Today we are celebrating the birthday of our beloved medical superintendent, Dr. Sudhir sir. Sir tried to escape. Yesterday he was not to be seen in Srikakulam. He left Srikakulam, but we won't leave him. Sir, we are very happy and we wish you all a very, very happy Uma. We wish you a very, very happy birthday, sir. So, Sanskrit happy birthday song to you specially. Dedicated to Sudhir sir. I think it's very easy to understand the meaning of this, that you'll have the God divine blessings always, and you'll attain more and more heights and be a role model for all of us as you are already now. Thank you, sir. Sir, please be acknowledged. So happy birthday to you, sir. Sir, please come onto the desk. Run, sir. Sir, run. Venkana is celebrating his birthday with Dr. Sudhi sir. I request Venkana to be onto the desk. మీరు లేకపోతే అసలు ఏం లేదు ఇక్కడ రండి. Please come. Very happy birthday to Venkana. Sir, please come onto the desk.
I am extremely thankful to all my colleagues, my seniors, and my junior students, and my all junior, postgraduates, for all your love and affection, concern for me. In spite of the day is being over, still you wanted to share this pleasure with me, and I'm very happy, and I'm always feel happy amongst you. Whatever may be the the situations that occur around us, that may trouble us, that may irritate us. In spite of all these things, I always enjoy your company. I've been enjoying it since the inception of this college, in spite of many difficulties, because of the strength given by all of us has driven me to move forward. Thank you so much. And when this is being done, this is my first time in my life that I am celebrating my birthday after it is over. So that brings me a thought. That means a rewinding. You are rewinding the day. Rewinding the day of birth. Instead of today, we are rewinding it to the yesterday. If really happens, if it happens in our life, if it is possible to rewind everything in our life, how the life it will be. That's what the thoughts coming into me when this event is being planned here. Yes, I really feel, yes, if my life is rewinded back, I would definitely correct many of my mistakes that I committed during my childhood, during my student days, during my professional days, during my all these years, last so many years being spent in GEMS. how beautiful it is to get such an opportunity. Maybe it was, that rewinding is a one thought. I think if it really happens, oh, life, many of the guilt consciousness, guilty things that we have in our mind because of certain things we have done without our knowledge, without our immaturity, without all these things could be corrected. Then we will become guilt free. So rewinding is also a good thought, giving me this opportunity, giving me this scope, the chance to think about rewinding. Our principal, Madam Dean, but all my colleagues giving this, the new thought process into my mind. I think I also thank them for this occasion. Thank you all. Thank you all for giving me this such a very lovely things, lovely mementos and all those things. And I wish I sail with you forever. Thank you.
Since this is your first birthday which we are celebrating, so from here onwards for the next 50 years, we'll be celebrating each and every year, sir. So please be ready for it.
I must congratulate the Dean Madam and all the staff and students of this institute. We are all behind you, sir, for your innumerable service that you have done to this institute. And you have sacrificed a lot. And then I hope you will not start another medical college. He made enough with this institute. And all of us, wherever you are, we are here or not, the entire staff and students of the college will remember you throughout our life. Wish you a long, long, long life. Thank you.
Once again, wishing Sudhir sir and Venkana Garu a very, very happy birthday. Please wait, have your piece of cake and then go. And on 27th April, that is Monday, we are celebrating Research Day, first of its kind, Mana College History Lo. So I want everybody to be present. And there are prizes for all the departments who have of course, one person from each department who has got the Best Researcher Award. And also there's going to be a Bolineri Research Award. For the first time we are giving. So I want all the postgraduates, all the faculty to be present on that day. Pushpa, nee birthday aayawala. Very, very happy birthday. Mar munchette cake cut chenchewalla. Cake tinese. Very happy birthday, Pushpa.